My name's Chris Schulz. I'm a trustee and clinical director of OpenSite. One of my personal highlights each year is the OpenSite AGM, where we traditionally have had the opportunity to hear a keynote talk from a guest speaker. But because of the current social distancing requirements, unfortunately it's not been possible to hold our AGM in the traditional format. It has undoubtedly been quite a remarkable year for all of us, and so I thought that it would be useful to share some insights into how clinical eye care has been affected this year, to provide a current update of where we are now, and also to try and glean some opinions of what the future might hold. So in this video you'll hear the views of Professor Andrew Lotery, Miss Christina Rennie and Miss Doreen Khan-Lin of the University Hospital Southampton, also of Mr Luke Clifford of Hampshire Hospitals and Mr Andrew Turnball of the Royal Bournemouth Hospital, as well as Miss Gill from the local Optical Council. I'm hugely grateful to each one of them for taking the time to share their insights and their views with us. How did your clinical practice change during the COVID-19 lockdown?
During the COVID-19 lockdown, our practice changed quite significantly. We stopped all our routine clinics and all our operating sessions and only saw emergency patients and those patients that we felt it would be unsafe to leave for too long a period before re-examining them. And this is both for adults and children.
Well, because of social distancing, we've seen a lot fewer patients in clinic than we normally would. And currently that continues with reduced patients in clinic, more patients being seen virtually.
Well, I think particularly right at the beginning, there were two key things we had to do. One was to protect our patients who might be vulnerable, so particularly the patients I see who are elderly or have diabetes and might be particularly vulnerable to coronavirus. And then also the fact that we were losing staff. So we had a lot of our nursing staff redeployed elsewhere in the hospital. So we had to make some very rapid changes. So it meant things like we stopped a lot of our operating apart from emergency work. And also we had an anaesthetist, so, apart from for our emergency list. So we had to make a huge change for that. And also in clinics, we couldn't see the volume we were seeing. And we had to really decide which patients do we need to see to prevent blindness. So we made a big effort to make sure we carried on our injection treatments. But a lot of people were put onto a very simplified pathway. So rather than reviewing them all the time and tweaking treatments like we normally do, we put them on a standard pathway so that we knew we'd sort of get the best treatment for everyone, looking at it as a whole, and trying to reduce as many of the follow-ups and clinic visits as possible, because we just didn't have the ability to do them. But making sure we could still prioritise those people who might be running into trouble and need to be seen.
So under normal circumstances, having a face-to-face appointment is crucial because you are hands-on, you're asking patients the story of what's been going on, and you are able to physically see the changes or the issues that they're coming with. And sometimes those things are quite microscopic, and we have specialist microscopic instruments in the clinic settings to allow us to identify diagnoses and make a management plan. So within the pandemic, face-to-face clinics immediately stopped. So at the beginning of the pandemic, everything came to a halt. Some of my patients are patients who have cancers, skin cancers around the eye. So the crucial thing to start with was to identify patients that potentially would be at risk or get lost, and to compartmentalize patients so that we could triage them according to whether they could wait and what time frame they could wait, whether they required a virtual clinic, and that would be either in the form of telephone or video consultations. And in the background, our IT team, who are absolutely amazing and have been a godsend, had been beavering away to try and support us to do that.
Well, personally, I furloughed all my staff, so I was just left here alone, dealing with telephone calls really. I had an optometrist on call who I could phone for advice. We would triage over the phone quite a lot. We would get lots of photographs sent to us of very attractive pictures of sore eyes, which we'd take a look at. And obviously we would then refer on into the hospital as and when necessary.
What does your current practice look like in comparison?
We have breath shields around all the equipment. We normally wear masks. It's very spaced out now. We've moved chairs so that we don't have lots of chairs together. It's all been spaced out. I don't have a big practice, so it's quite easy to control the flow of people. We've had to work to an appointment system for collections and adjustments and such forth, which we've never done in the past. It's been a drop in when you like, but we're very controlled now in letting people in.
Our current practice is much more similar to how things were before COVID, in that we are carrying out regular clinics and regular operating sessions, but everything is at a much reduced rate, so we aren't seeing the same number of patients in each clinical session as we did previously, and this is to allow for time to make sure everything is cleaned thoroughly between each patient.
Well, things are still very different from normal. Because of social distancing, we just don't have the ability to see the volume of patients in the clinic that we used to. We're seeing probably about half of what we normally do. So my normal 40-patient clinic on a Friday morning is now about 20 patients. And so that's a real challenge for us to decide, well, who do we see, who don't we see? We are slowly increasing numbers, but it's a long way off what we normally do. We're starting to do a lot of things very differently. So a lot of patients who we can't necessarily see face-to-face in the clinic, we're bringing them in for scans, and then we're looking at the scans and either giving them a report or phoning them up about what we're seeing on the scans. So it's a way of trying to get more people through, but not taking up cubicle and clinic space all the time. Our operating's back. We're doing quite a lot of operating. Again, the list is slightly smaller than normal because of all the social distancing requirements. So we're doing lists in Lymington, in Nuffield, at the Spa, at Tegra. So we're using the private sector as well as the NHS to really try and get our numbers of surgery through. And I think our operating list is now back sort of reasonably under control again.
Obviously, there are always going to be some patients that have to be seen face to face. And whilst I'm still restricted in being able to do that myself, I have organised it so that my fellow, she sees them and I support her remotely. And somehow we've got that down to a fine art, and we now have expanded the number of face-to-face consultations that she's able to do. So she's my eyes and ears on the ground, if that makes sense. And that the decision making I can then make one floor above from the office, because our IT systems allow us to see the photographs, communicate, and it works really well.
What positives can you take from the past 6 months?
Well, I think there's several things that have been really interesting. I think the pace of change the NHS has managed over the last 6 months has been amazing. Normally we're quite big and bureaucratic, and it can take a long time to get things done. I have to say we have rapidly put things in place.
That we already knew that the NHS staff and the supporting staff all work well in times of crisis, when there are emergencies. But I think what has been demonstrated is that when you reduce a lot of the bureaucracy, the NHS works even more efficiently.
Whereas previously a lot of things in the NHS would have taken a long time to be developed, new ideas can fester in committees and planning meetings. Recently, over the last few months, when we've suggested that we do things in a different way, or we've had innovative ideas, it's been amazing how quickly these things have been processed and acted upon, and we're really seeing a great period of change and improvement within the health service.
It's made people think about doing things differently, being more innovative, and things that you thought weren't possible suddenly are. And in a way, it's a surprise, and it's made things quite enjoyable. It's definitely improved quality of life. It's improved safety in many ways. And above all, for my group of patients who are over 70s majority, it's made them feel safer that we have been able to look after them without having to drag them into a busy hospital clinic.
Well, we've become very efficient at using virtual technology, and we've looked at ways to increase our capacity with virtual clinics where patients are imaged and then informed of their outcome of their appointment afterwards. And I think because of the problems we had with capacity and not enough slots to see patients before COVID, this is very helpful that we're now developing more efficient pathways so we can see more patients. And And so there's been some investment in retinal cameras and off-site locations so that we can see more patients in the long term.
Fortunately, we didn't lose any of our medical staff in the end, but lots of our nursing staff and our theatre staff were redeployed elsewhere to work either in mainly D or on the COVID wards. And I think, that retraining was amazing. And I think we get some benefit from that going forward, that a lot of staff I've spoken to who've come back from those areas have said actually they were really nervous about going, really dreading what they might find, and having worked in some of those environments either before or for a long time, actually came away having learnt a lot and brought back really good skills for us in the eye unit. So I think it's been a benefit for us in the long term from patients being redeployed.
What's your biggest concerns about ophthalmic care over the past 6 months?
There are people that have missed opportunities to be seen. A lot of people, I heard stories of people losing vision in an eye, potentially a retinal detachment. And when they were told they really needed to go to hospital, they declined because they had two eyes and they could see out of one of them, and they didn't want to go into hospital and get COVID.
And my biggest concern about ophthalmic care over the past 6 months is the build-up of patients waiting to be seen, and some patients not getting their treatment in a timely manner.
I think the biggest concerns have been the patients we've not seen. You always sort of slightly worry. We try to triage that we take our high-risk patients, and the low-risk people we're postponing because we can't see them at the moment. It's always that slight unknown. Is there something out there we're missing? And the only thing I would say to people who are listening is if you've got concerns, if you've had recent drops in vision or concerns about vision, then do phone in. We do now have a really good phone triage system for the eye casualty, so you can get advice if you need it. I think that's some of my concern. The other thing I think are patients who have decided not to come in because they're worried about coming into the eye unit. Would they pick up COVID? There's a lot of concern among particularly our vulnerable patients who may have multiple health problems or be elderly and therefore more at risk from COVID. And I think it's a concern, is that balance, are they risking their vision versus risking their health? And we do know a number of them who've not come up to see us because they've been worried. I think what I can do is say to people, well, we are taking lots of measures with social distancing, with cleaning. We're trying to make sure we can keep that, things as safe as possible for people when they come through the department. We're separated from the main hospital. We have very strict rules about which patients can go where now within the eye unit and within the rest of the hospital. And even the staff, we're not supposed to be mixing throughout the rest of the hospital. So, we are trying to isolate to be a little bubble on the edge of the hospital where we can safely see our patients. I think that's really, for me, the other concern is what's happened to those people who didn't come. We would still like to see them if they want to come up.
What are your hopes for eye care moving forward?
My hopes for eye care moving forward are really two things. One, that there is enough investment in ophthalmology to provide all departments and community settings with the appropriate and necessary equipment and staff to make things run as efficiently and effectively as possible, and also nationally to increase the numbers of ophthalmologists training to become consultants, as without this increase in numbers we really won't get on top of the huge numbers of patients that need to be seen and also are currently being seen and managed within the service at the moment.
I would hope that sense of enablement and the way that things can be done in an efficient and effective way, I'd hope that would continue because it's been a real revelation how quickly significant changes can be made for the better when the pressure's on.
And I think this has really been an impetus to start making changes that we've all talked about the last few years. Everyone sort of has an idea of what we should do in terms of creating more capacity. We can't magically, create more ophthalmologists, but what we can do is work differently with our community colleagues. We can work differently with our optometrists. I think the biggest thing that will come over the next year or two is really getting those other providers and systems in place. So we as an eye unit don't need to do all the work. We can make use of our community providers. And I think going forward, there will be the ability for optometrists to do much more work and perhaps share images with us, share information with us, so we can say, actually, yes, we need to see that patient, or no, we don't need to see a particular patient.
Well, I think The pandemic has shown us, particularly in this area where I am in Portsmouth and surrounding, that we need to have much greater links with the hospital, because optometry could have been a lot more helpful to the hospital if those things had been in place. So hopefully we could link, forge more links with the hospital and actually get that more joined up, because there are many parts of Hampshire where that system is working really well. They have good links with their hospitals, they have good mech systems, they've converted to queues, but in my area, we haven't.
In the even longer term, of course, artificial intelligence, I think, will be a really interesting one. We know already that machines can read a lot of the scans that we take, and to a very high degree of accuracy. They may not be able to give the complete diagnosis, but they give an indication, yes, this might be a wet macular degeneration, or no, it's very unlikely to be. So again, that can begin to triage and speed up that whole process of referral, and pick out which patients we really do need to see in the eye and which might be able to be seen elsewhere because they don't have features that are worrying. And that, I think, if we can't magically train a lot of workforce very quickly, actually using our technology may be one way of stepping in and filling that gap for us.
But as I say, I think the developments in terms of developing ways to see patients in the community with virtual appointments, which many patients like, I think is a way forward to help us in the long term in managing patients so that they get the care that they need in a timely fashion. So there's positives and negatives from COVID, but it may help us in the long term get to be a more efficient eye service.